Well, thank you, Dr. Fitzpatrick, for inviting me and including me. This is not an audience I generally speak to, a clinical audience. In fact, I spend most of my time in lab. But so you guys can put down your notebooks. I know this is a CME session. I'm not going to talk anything about standard of care, but hopefully if you were to take notes and then you were to go back 5 years from now, hopefully some of what I say may actually become relevant. So as you've heard from everybody today, this is a really exciting time in prostate cancer. And since 2010, we've all talked about there's been 5 new therapeutic drugs that's been approved by the FDA. They improve survival, actually, in prostate cancer. And as you heard from Maha Hussein today, and what Dr. Sher is talking about, prostate cancer is actually the only common epithelial malignancy that there is really no predictive biomarker for response. So what you probably, unless if you live in my world, what you probably don't know is that also in 2010, since 2010, there has been 500 prostate cancers that's been sequenced. So this is what we talk about when we talk about precision medicine and the ability to match genotype with treatment. But there's a good reason why you haven't heard about this, is because so far we really don't have this link right now. And what I want to spend the next 25 minutes talking to you about is give you an overview of what we found, talk to you about some of the challenges for finding biomarkers for precision medicine, and as a disclosure, specifically talk about what we're doing in MSKCC to try to meet those challenges. So as you know, the current practice in CRPC is to take a patient and essentially use clinical judgment, whether it's pain, visceral disease, the pace of disease, or age, to select the next line therapies. And I'm sure all of you, me as a physician and all of you as physicians, use these criteria to select the next therapies. But in fact, there is absolutely no data that any of these really is, there's no class 1 data. Any of this should help us select which of these therapies. In fact, there are just guidelines, for example, for Ciprucil-T and radium-223 as far as which patients meet the criteria. But those criteria are all designed by rationally by the the physicians that designed the phase 3 trials. In fact, there is no data that suggests those criteria has data behind it. So precision medicine, or the paradigm precision medicine, is that if we were to take patients with CRPC and to genetically characterize the disease and build a comprehensive knowledge database, hopefully that will help us select either the currently available agents or the clinical trials. So probably the best, as many of you know, the best model for precision medicine is lung cancer. EGFR mutations is a validated molecular biomarker for response to EGFR inhibitor gefitinib. And this is a phase 3 trial in Japan looking at patients who were randomized to either receive gefitinib or carboplatin and paclitaxel as first-line therapy. And as you can see, if you would take the overall population, there's no difference in progression-free survival, at least in median progression-free survival between the two populations. However, if you were to look at the patients that have the EGFR mutation, you can see that patients on gefitinib perform much better, and the patients without EGFR mutation perform much worse. So as a poster child for precision medicine, this is a review from William Powell in 2011. You can see that over time, lung cancer has been divided more and more into multiple subclasses molecularly. So from the definition of KRAS to EGFR mutations in 2004 to multiple subtypes that are sensitive to different treatments. From within EGFR mutations, the type of mutation could define various different sensitivity to EGFR inhibitors, to ALK fusions, and BRAF mutations and other mutations. So what have we learned so far in prostate cancer, and why is prostate cancer so difficult? So over the past 3 years or so, we've built a large knowledge database from several large-scale prostate cancer oncogenomics projects. I'll just tell you about some of them. So the first one was performed at MSKCC, and that was using targeted Sanger sequencing. And over the next several years, whole exome sequencing became very accessible, and that was performed on a number of studies looking at both primary prostate cancer and also metastatic prostate cancer. In particular, a large study in Michigan on autopsy series of CRPC. There are several large studies now. Data is available from large TCGA study of over 300 whole exomes has been performed, and also there's an ongoing stand-up to cancer trial of 500 whole exomes in castration-resistant metastatic prostate cancer. Whole genome sequencing is also being published right now, and that gives us additional information. So, so why now? Why is I think, looking forward, why are we doing these studies? Well, one of the important drivers is that it is becoming cheaper and cheaper to actually perform whole genome studies. So this is going to be, in the next several years, extremely accessible. In fact, the cost to do a whole exome or perhaps even a whole genome on your patient, especially on the initial biopsy material, is going to be no more than the cost of performing a FISH or other studies that you do right now. So this is data that's going to be extremely accessible, and probably the cost of biopsy soon will be more than the cost of performing the exome, but what can we do with it? So as part of a large ongoing clinical trial, in fact, this is multiple clinical trials, and this is something that you should be aware of, and perhaps you can refer your patients, is there's AACR Stand-Up to Cancer consortium that has a goal of sequencing 500 patients with castration-resistant prostate cancer. And this is essentially a paradigm right here of hopefully what we will do for patients in the near future. And that is perform tumor biopsies and perform sequencing on individual patients' tumor after they've enrolled in trials, obtain the results of the mutation analysis, and then have multidisciplinary tumor board that analyze these results and recommend either clinical trial, standard of care, or perhaps even off-label use of known drugs. And these are the multiple institutions are involved. So I'm just going to spend a little bit of time, at the risk of offending some of you, to talk about the different types of mutations that we find in cancer. And this gets you to the heart of the difficulty of how we can apply this to prostate cancer. So, I put mutations in parentheses here, but in cancer, there are essentially two broad ranges of mutational processes. One is, what we typically think of as mutations. So single nucleotide changes, a KRAS mutation, a BRAF mutation, V600E, for example, or small insertions and deletions that we also see, for example, in EGFR or KIT in multiple tumor types. And the second type of mutation is genomic rearrangements, such as amplifications, deletions, or fusions. These mutations are easy to target because they define the lesion, whereas these are difficult because often the amplifications and deletions involve large areas where we do not know what the true driver mutation is. So if you were to look across tumor types, now there has been many large-scale sequencing projects in a large number of tumor types headed by the TCGA. You can see that many tumor types have a large number of mutations. So this is a recent publication in Nature studying 21 different tumor types. And you can look up their website. You can see that there are mutations that are considered to be highly clinically significant or borderline significant. And this is colorectal cancer, for example, lung cancer, breast cancer. These are the common culprits that you all know about. For example, APC is the most common in colorectal cancer, KRAS in lung cancer, PIK3CA in breast cancer. If you were to look at this metric from everything we know about prostate cancer, this is what you see. So the most highly significantly mutated gene is SPOP, which is a ubiquitin ligase, which you may or may not have even heard of. SPOP is like APC, which causes degradation of beta-catenin. This causes degradation of a large number of proteins, but in fact, the protein that is oncogenic is not known. But this occurs in approximately 10% of prostate cancer. And then there's other much more rarely mutated genes in prostate cancer. So prostate cancer is not a very mutational cancer. But if you were to look at the copy number landscape of prostate cancer, so I'll just walk you through this. So this is looking at our data set that was published by Barry Taylor in 2010, and looking at either genomic gains or losses throughout different chromosomes of prostate cancer. This shows that genomic rearrangements is actually the predominant mode of mutagenesis in prostate cancer. So if you were to look at this, you can see a large number of these gains and losses are very broad, covering many of these areas, covering hundreds, if not thousands, of genes. There may be some genes that, if you were to read the literature, are claimed to be genes that are causal lesions in some of these gains and losses, but those data are not very strong in general. There are just several genes that are well known with these very sharp peaks of losses, and they're shown here. So in chromosome 21, there's a deletion between TMPRSS2 and ERG that causes the interstitial TMPRSS2 ERG fusion. In chromosome 17, there's a sharp deletion in a subset of tumors that is a loss of P53. And of course, in chromosome 10, there's a deletion of P10. So if you were to take the mutations and these copy number changes together, this is what you see in prostate cancer. So if you were to separately look at primary prostate cancer and CRPC, essentially S rearrangements is the most common, as most of you know. It occurs in about 50% primary prostate cancer and also 50% CRPC. P10 deletion occurs much more commonly in CRPC, about 50%, and about 10 to 30% primary prostate cancer. And AR mutation amplification is non-existent in primary prostate cancer and occurs in 50% or higher of patients with CRPC. So when we target lesions, we like to target lesions are the drivers, the initiating mutational events. And what you can, one estimate is comparing between primary and CRPC and looking at mutational events that are comparable, whereas mutations that occur only in CRPC theoretically is not an initiating event, but a progressive event. You have to look at this with caution, though. For example, if you were to look at P10 deletion, since it does occur in primary prostate cancer and more commonly in CRPC, the two possibilities are either that this is at times a progression event, or that it is the primary tumors that have P10 deletion that eventually metastasize and become CRPC. And in fact, data suggests that both of these are true. So among all these, in fact, the only two that we know are initiating events have very good data are S rearrangement and SPOP mutation. They're found in primaries, and if you were to look at various metastatic lesions, or as Howard said, if you were looking at CTCs, all the cells are the same. If you were to look at P10 deletion, AR mutation, they are heterogeneous. So there are various deletion events. These are the next most common group of mutations. And here I put both in parentheses and not in parentheses. And once in parentheses means that in primary you see a hemizygote deletion in these areas. However, in CRPC you begin to see homozygote deletion in these areas. So these are areas where there are generally wide deletions, but in CRPC you start having small homozygote deletions, showing that these are indeed progressive genes. And what is very interesting and challenging for prostate cancer, though, is that if you do enough sequencing, you find a lot of mutations where we theoretically can drug them, but they're of very low frequency. So we heard a little bit today about BRCA1, BRCA2. There's also ATM mutations in prostate cancer, 1 to 2%. Heard about PIK3CA mutations. There are RAF fusions. In fact, rarely there's a BRAF V600E mutation. There's RAS fusion, CDK4 amplifications, AKT. And you know that there are both either clinically approved drugs or experimental drugs that can target each of this. So for precision medicine, the first thing I'm going to talk about is what to do with patients in this category, and why it is important to have a database, and so you sequence enough patients, you understand exactly how many patients fall into these categories. So perhaps this would be an interesting question. If you had a patient, you sequenced with prostate cancer, and they had a BRAF V600E mutation, well, what would you do? Would you treat them off-label with vemurafenib? Would you treat them with standard therapy? Or would you put them on a clinical trial? What clinical trials are available? Well, I think it is a little bit dangerous to put patients off-label, for example, on vemurafenib, because from the experience with, for example, melanoma and colorectal cancer, we know that just because you have a V600E mutation, the histology still is important, and we don't know what the answer is for prostate cancer. So as part of these large-scale clinical trials that involve sequencing over the next year and has already been started, are trials that we term basket trials, and I think a lot of you know about these. So these are trials that are not histology specific, but meant to be mutational specific. So at MSKCC, we have basket trials specifically for both PIK3CA mutations and BRAF V600E mutations. And these are trials where you can enroll patients with essentially any histology. And you want to have a big enough cohort so you can ask whether that within that histology, this mutation is responsive or not to the drug. So if you were to have a patient that have this, I think you should probably refer them to a center that has one of these trials. So for the rest of the talk, I'm going to talk about the most common mutations in CRPC, and talk about our work as far as trying to understand how they can be predictive of responses. So I'm not going to talk much about this, but one of them. But I'm going to briefly talk about AR mutation amplification and splice variants. So this is clearly gained during selection pressure from castration. This is never seen in primary prostate cancer, and it's seen very commonly and also heterogeneously in patients who have castration resistance. So as Howard had initially alluded to quickly, enzalutamide itself was designed specifically as a model where tumors became resistant to castration and bicalutamide, and they became resistant because they overexpressed AR. So I think from probably about 10 years ago, where patients who had become resistant to castration were called hormone-independent or AR-independent prostate cancer, when they thought AR was irrelevant, to now where the paradigm shifting where we think AR is relevant for everybody. There's actually a range, and when patients become CRPC, there's probably a range of patients who is still dependent on AR, and there's a range of patients who become less dependent on AR, and the most furthest along those ranges, patients who become neuroendocrine and become small cell, where they completely lose AR. So the emerging data and data from the laboratory is that in patients who have AR mutations, AR amplifications, actually, they have locked themselves into an AR-dependent state. So likely they will be either sensitive to this abiraterone or enzalutamide, or if not, they are at least AR sensitive, and there would be good candidates for other treatments for that targets AR. One example of this is, for example, if you were to look at patients who become small cell prostate cancer or neuroendocrine prostate cancer, that at the end of the disease, maybe up to 10 to 20% of patients who eventually die from prostate cancer. And those patients, almost none of them actually harbor AR amplifications. So it tells you that probably when the tumor decides to amplify the AR, they've locked themselves into an AR-dependent state. So next I'm going to talk about S rearrangement. I'm going to start by talking about PTEN deletion, work that's been alluded by both Dana and Howard of Brett Carver in Charles's lab. So just to remind you, So this is the pathway of PTEN. So PTEN loss activates the PI3K pathway. So PI3K is lipid kinase, phosphorylates PIP2 into PIP3, which is a docking lipid that allows AKT to go to the membrane, where when AKT is activated, it activates downstream mTOR. Importantly, there are a number of different pharmacological agents that inhibit this pathway, including PI3 kinase itself, AKT, and TOR. Now, there is no inhibitor directly of PTEN, and that may be one of the important issues. So as some of you may know, one of the most best predictive biomarkers for response to PI3K inhibitors are PI3K mutations. So in most diseases, if you see the mutation, you hit the mutation, and there's no inhibitor of PTEN, so we have to try to hit the pathway. So one initial discoveries that was made by Brett and Haley in the lab was that if you were just to look at human prostate cancer, and you were to look at the level of androgen signaling, you can see in that patients with PTEN loss had lower androgen signaling. So this is a bar that essentially adds up all the androgen responsive genes, like PSA. So essentially what we're saying is that patients with PTEN loss have lower, for example, PSA and other androgen responsive genes. And this is actually very much seen in the clinic, as we often see that higher grade and more aggressive tumors make less PSA. So in order to study this process, Brett made a mouse model of PTEN loss, and this is just a lingo PTEN flox. And you can see that in a mouse model of PTEN loss where the mouse developed high-grade PIN, they also express less AR target genes. And it is this lower expression of AR target genes that results in a lower dependence of AR. So if these mice were treated with enzalutamide, the tumors did not respond very well, whereas a different mouse model of prostate cancer that is driven by MYC amplification responds very well to AR, to AR blockade. So what happens if you were to treat these mice with a PI3K and mTOR inhibitor? So BEZ235 is an mTOR inhibitor. And the initial expectation was that they would respond very well. However, you barely see a response either. So the reason behind this is that, well, once PI3K is inhibited and the PI3 kinase pathway is tampened down, AR turns back on. So if you were to look at AR target genes in mice, which is probasin, IKX, PSCA, they turn back on to the original state. And therefore, AR is now the survival signal when PI3K is inhibited in these PTEN loss. So this is the rationale for use of dual inhibition of enzalutamide and BEZ235 in this mouse model. You can see in the dual inhibition, the mice have dramatic responses. This is an MRI of the mouse prostate. This is a tumor prior to treatment. 35 days after treatment, you barely observe the tumor at all. So this has led to a number of clinical trials. Both Dana and Howard had mentioned one of them, which is a ARN509 plus everolimus. This involves a pretreatment biopsy, exome sequencing of the biopsy, characterization of the CTCs, as has been mentioned. There are other clinical trials based on this observation, including a trial of abiraterone acetate and BKM120, as well as another clinical trial by bicalutamide and the AKT inhibitor MK2206. So what about ETS? So when we look at the data sets, S rearrangements and PTEN deletion have a very high level of co-occurrence. So if you were to look at the MSKCC data set, for example, among patients with PTEN loss, they're almost invariably S rearranged. And this is even more dramatic when you look at CRPC in the autopsy data set. You can see that among the PTEN loss patients, are heavily S rearranged, whereas in the PTEN intact patients, they're mostly S negative. So this suggests that S and PTEN cooperate and may affect both treatment response and the biology of the tumors. So next we made a model of PTEN loss in combination with S over expression. And this is very interesting in that, so as I mentioned before, if you have just PTEN loss, the mice develop PIN but never develop cancer. And one of the reasons that we think this is true is because they lose AR signaling. So the loss of AR signaling constrains the tumor from developing into fully invasive cancer. If you were to have now both ERG expression and PTEN loss, there is now full-blown cancer with ERG positive cancer. And what's very interesting in these mice is that, as I showed you before, when you lose PTEN, there is loss of AR signaling, but when when ERG is expressed, it actually restores AR signaling. And so what this model shows is that when in the setting of both ERG overexpression and PTEN loss, there is now two pathways are activated. Both PI3K is activated and AR signaling is reactivated, and this causes aggressive prostate cancer. In fact, this is seen if you were to look at the total AR activation in both the Michigan set and MSKCC set. So this will predict that S positivity may predict for sensitivity to AR inhibition. And this may be true. This is looking at the 302 trial that was presented by Dr. Tard in last year's ASCO, and it shows that in patients with S rearrangement, they do poorly, except that they respond very well to abiraterone, and perhaps even better than patients that did not have S rearrangement. So what about our mouse model? This did not turn out to be true in the mouse model, and we think the reason this did not respond is because in our mouse model, ERG is driven in an AR-independent way. So what this suggests is that we need to, in patients with PTEN loss and ERG rearrangement, we need to inhibit AR, PTEN, and we have to make sure that ERG itself is inhibited. One of the reasons we use mouse models, and one of the reasons is that because there's no more rapid models to predict drug sensitivity in prostate cancer. So in prostate cancer, in vitro models are lacking. And this is a recent paper published looking at Cancer Cell Line Encyclopedia. And this shows that now we can do rapid screens looking at various drugs, provided there are a number of cell lines that are available. However, in prostate cancer, currently there's very few cell lines that are available. And one of the things that we're working in the lab now is to be able to culture prostate cancers directly from the biopsies that is being performed. So we've developed a method together with Hans Clevers in the Netherlands of performing 3D cultures and allowing us to generate novel prostate cell lines that can recapitulate prostate cancer. And this is just an example of 3 patients. And this is their in vivo histology. So after 3D biopsy, after biopsy and 3D culture, we can generate prostate cancer that essentially matches the initial histology. Not only do they match the histology, they also match the AR status, the PTEN status, and the molecular lesions. And this is to show that we have performed genetic characterization of these in vitro cultures. And compared to the normal cell lines that are currently used for analysis, these cultures recapitulate the copy number variations and also the mutational profile of prostate cancer much better than the currently available lines. So I'm just going to sum up by referring to the Institute of Medicine and look and the paradigm of going towards precision medicine. And one of the reasons that right now we don't have the precision medicine in prostate cancer is because our knowledge network is lacking. So with biomedical research and also from clinical research and all the observations, hopefully this can build more subtypes of prostate cancer, a new definition of subtypes of prostate cancer, and then over the next years, truly have precision medicine in prostate cancer. Thank you.
Thanks very much.